really takes a special person, I think, to whatever level of care you're providing within hospice, whether it's just the home health aide or the CNA to the RN. I think it takes a special person it has to be in your heart.
It is a team.
Yeah.
It is a team, and we all cohesively pull it together for our patients.
Mm-hmm.
They're all very, very important. From the time I meet them until the time a nurse goes out to say her final goodbyes and be with the family.
Right.
And hospice is still underutilized, and it's underutilized because it's misunderstood.
So what is hospice?
Hospice is a type of care. It can be provided in the home, in a nursing home, in an assisted living, in inpatient unit, which we do not have in Cumberland County right now. Hospice patients come to us when they have terminal, life-limiting illnesses that have progressively gotten worse, and they are no longer seeking aggressive or curative treatments. People tend to equate hospice to a cancer diagnosis, which it was initially, and it still is. However, that's easier to conform to because they have stopped chemo, radiation, no surgical options. It's our patients with COPD, congestive heart failure, renal failure. There's a full list of them. And these people don't know that they can receive care from our team. So that's what I do all day long. I meet with physicians, I meet with families, and honestly, Matt, if I can change the way that one person embraces and perceives what hospice truly is, I've done my job for that day.
And I've seen hospice, when I started visiting angels here in Fayetteville 2.5 years ago, I definitely had the wrong perception of what hospice is, and I'm so glad that I've been educated by people like you, and we definitely promote it as much as possible. If we see someone who's eligible that we believe, we're going to call someone like you, have you come have a talk with them. Maybe they're not eligible, but maybe they will be in 6 months.
Right.
Something like that.
The sooner the better. If they have that information and it's alleviated some of their fears, and believe me, I've heard it all. I've heard that hospice takes their homes.
Yeah.
It goes into their bank accounts. We're not bankers, we're not realtors, either one. So if I can give them that information, and usually Sharon will call back every week or so to check with them to see how they're doing, if they're better as far as engaging in hospice. And we send our staff out to get them admitted.
It's the education. That's the beauty of hospice. For me, I wish physicians would see that as being able to do something else when they feel like there's nothing else to do for a family. The patient and the family benefit so much more if the physician will refer them when they feel like their prognosis is 6 months or less versus waiting until the patient is weeks or days from death. The family misses out on so much support, so much education on what's going on, and our goal is quality. Our goal is trying to help people live better for however long they have to live. Studies have shown that if people's symptoms are managed, their pain is under control, their shortness of breath is under control, they live longer, sometimes on hospice. I don't know the exact, 3 to 4 months I think is what the studies show versus not being on hospice. And I really think that has a lot to do with the fact that they're comfortable and they're having a good quality of life versus waking up every day, being miserable, being sick, not wanting to do it anymore, being tired and giving up. We come in and we give them that little spunk back, we get them where they're comfortable, and then they can spend time with their family. They can have that closure with their family, with their kids and grandkids, that if they're miserable, they don't necessarily want. So for me, hospice, that's a big thing, is making sure that we're focusing on quality, not necessarily quantity.
Yes, and with us, we do non-medical home care. personal care. I feel the same way as don't wait until the last minute. Don't wait until you need 24-hour care.
Right.
To call us. Call us beforehand. Have us come in, have you get used to the process before you're at that stage where you need someone around the clock. How do we work together, with us, with non-medical personal care and home care and hospice?
I've had that happen often, and I have the conversation with families when I go in. Our team consists of nurses, social workers, CNAs, volunteers, pastors, bereavement coordinators. Our CNAs go in to do one-on-one with that patient, to bathe them, to help them get dressed, to change their bed linen. They're rarely there over an hour,
Right.
hour and 15
And
minutes.
they provide a lot of help with the families too, because you've had somebody that's, up walking around and taking care of themselves, and something happens and now they're bedbound. Those families don't know how to change the linens with somebody in the bed, or to change an adult brief. They don't know how to bathe somebody, and our CNAs are really great at showing them how to do those tasks, so that on a day-to-day basis, that person that's bedbound is taken care of, and they're not developing pressure ulcers and things like that. So our CNAs are a big part of the education that the nurses and the social worker and the chaplains providing.
Right. But hospice, a lot of times, like some people get the misconception that when they get hospice, that's all they need.
No.
They need more. If you
absolutely.
do have someone that's bedbound, and if the family isn't able to, physically or time-wise, to take care of that person, that's when they need someone like us, right?
Exactly.
Yeah,
Because
do work
when
hand in hand.
a caregiver is a part of the equation.
Right.
You
Whether
know,
it's the family or
or
someone
you,
like us.
Absolutely. And I try to make sure that the patients understand that when I meet with them. There is a difference. We work together to add all the pieces of the puzzle together, because when it comes down to it, nobody should die in pain, alone, or afraid. And when we're not there and your people are there, that pulls that puzzle together.
Right.
Well, and then, when we are there, and the CNA is there, the nurse is there, and it's an hour, hour and a half, 2 hours, that caregiver still has the whole rest of the 24-hour time period
That's
to
right.
be a caregiver. So if you all can come in and provide 2, 3, 4 hours for them, that's that much more time that caregiver can take for themselves, that they can lay down and take a nap, or they can go sit out on the porch swing and read a book and do some self-care. And that's important when you're a caregiver.
Exactly.
Is to focus on
Absolutely.
self-care. Absolutely we focus on the patient, but the beauty of hospice is it's a holistic view of things, as I'm sure for you guys that is too. The caregivers are just as important. And if they're not practicing good care, they can't take care of that patient.
That's right.
So together, if we're in there for a few hours and you guys are in there for a few hours, that's that much more time that caregiver has for themselves to be able to take a breather.
That's
Which
right.
makes it easier for them then to provide the additional care that they need to when we're not there and you're not there.
Yes.
The goal is to keep that patient where he or she wants to be,
That's right.
which is at home. They may be in a hospital bed, they may be in a recliner, sitting beside a window, looking at a pear tree they planted 40 years ago. Those are the memories, the fact that their grandchildren can come, the fact that everything around them is familiar, especially with patients with cognitive disorders.
Yes.
But, we want to work together to make sure that they can stay there.
Yes.
Yeah.
And like you said, studies have proven as well that when you're home in your own environment, you do have a better quality of life.
Absolutely.
And you do live longer.
Right.
Do you need a doctor's referral for hospice?
Yes.
You do? Okay.
Now, I can go talk to anyone,
Okay.
and I do. In the grocery store, at church,
Yeah.
everywhere I
Right.
I guess that's the time you met me, you knew that hospice is right here for me.
Absolutely.
Yes, absolutely. If someone calls the office and says, I'd like to talk to someone about hospice, can you come out? Sharon usually calls me. I go out and have the conversation. If we think they're ready, then she can work with the physician and their staff to get everything we need. And we're fairly quick on getting that done and getting that patient admitted.
Good.
Our
Yeah.
goal is same-day admissions.
Yeah.
So our goal in a perfect world is we get a referral and we send a nurse out immediately. We do that probably, I would say 95% of the time if we get a referral, unless the family wants another day. Sometimes we get a referral and I call to try to arrange for a nurse to come, and they don't want to do it for 2 or 3 days because there's some additional children that need to be there that might hear it. But it's definitely, like Debbie said, she can go out and talk to anybody. We don't have to have an order to talk to somebody, which is different than home health. Home health has to have an order to go out and do an evaluation. We can go have a talk. We can do an evaluation of the situation, not a hands-on assessment, but an evaluation. And then we can reach out to the physician and let the physician know, you know, this family's reached out to us, home health has referred them, you guys have identified a patient that might be appropriate. And our account rep has gone out and visited with the family. Sometimes the families put the brakes on, no, I don't want hospice. But Debbie's given them information. She provides them with some literature, sometimes some pamphlets or something, so that they have something in black and white. And they can think about it. It's not a commitment when Debbie goes. And I think she makes that really clear to the families. You're not signing up for anything. I'm just coming to talk to you. I'm coming to give you information. Because a lot of she does a really great job of explaining the support that they get, not just from the nursing staff, but from the social work for emotional support, from the chaplain for spiritual support, for a volunteer to sit with somebody so the caregiver can run to the grocery store. And she lays all of that out for the family. And the question I get when I do that over the phone, if Debbie's not available, I'll do what I call phone informative and share all the same information. The question I get asked after I explain all this, if we provide medications related to the hospice diagnosis, we provide supplies, if you need briefs or pads for the bed, and we provide DME if you need a hospital bed and you don't have a hospital bed, or you need PRN oxygen, which as needed oxygen, Medicare doesn't pay for, but we can.
Yeah.
And my question I get from families after that whole big spiel is, so much is that going to cost? And the beauty of it is, there's no out of pocket for families. Medicare and insurance pay hospice at 100%. So all those benefits of all those support systems, all the DME and supplies, the families are just blown away because, is this too good to be true? Well, it's absolutely, it's good.
Yeah.
And it's true. You get it and you're not having to pay for it. So, you know, that's a super important thing I think that families need to hear too, is it's not going to cost me a gajillion dollars to have hospice in here because they're going to do all of this.
So with hospice, if you're there caring for someone as far as like COPD, does that person still can they still go to the hospital, or do you guys kind of take care of everything at that point? How does that work? So
they can go to the hospital. We talk to them though and encourage them to let hospice come in to see if they can maybe manage, if we can maybe manage the symptoms. A lot of times, because the nurses are going in 1 to 2, 3 times a week, or as often as the need is. If the patient is having a lot of symptoms, they may go every day.
Yeah.
And they're seeing this patient from week to week, visit to visit, and they see things that maybe they can get some medication changed, COPD or congestive heart failure, for instance. Maybe they see somebody whose ankles are swelling that's not usually swollen and their lungs start to sound a little crackly. They can call the doctor and get some medication.
Something that they can get ahead of it before.
Absolutely. And if we can nip it in the bud, you know, this, and get the symptoms managed, then we can effectively keep somebody out of the hospital. And a lot of times these people don't want to go back to the hospital.
Right.
By the time they're on hospice, they're tired of being in the hospital. They're tired of going to the doctor.
Especially now.
Oh yeah, absolutely.
Nobody wants to go to the hospital.
And it's hard. It's very taxing.
Yeah.
Many of these people have portable oxygen tanks. They have wheelchairs. They have a spouse who is trying to get this patient in the car. it is a lot on a family member to try to do that. So we do encourage them from the beginning, call us first. If it's non-related to the hospice diagnosis, many times they'll go. If they fall
Right.
and hit their head on the table and they're bleeding, you know. But for the most part, you know, if they call us, we have 2 medical directors, both are local. Our nurses are able to take their phones out, call one of them, and they take care of the problem.
Yeah,
The medication changes. Again, like she said, in that, we always refer to the Medicare hospice benefit, but it's the same with Medicaid, and private insurance carriers tend to follow suit.
Right.
If they need a hospital bed, a nebulizer, oxygen, a bedside commode, tub transfer bench, we have all that delivered. And Medicare is not paying for that, we're paying for that. So,
Good.
Well, and I think too, the thing about keeping them out of the hospital is there's a nurse available 24 hours a day, 7 days a week. So when do people typically get sick? Really sick, 2 o'clock in the morning. And what do? Your doctor's
asleep.
Your doctor's asleep, and it may not even be your doctor that's on call.
Right.
So you call EMS and you send somebody to the hospital. With hospice, they can call hospice. They can talk to the nurse. The nurse can talk them through maybe just giving medications and then make a follow-up phone call to see if that intervention was effective or not. Or if the need exists, the nurse is going to go out at 2 o'clock in the morning and make a visit so that they can educate the family, they can support the family, because that's scary when you've got somebody that has a terminal illness and it's 2 or 3 o'clock in the morning and they're having symptoms, they're having pain that their pain medicine isn't controlling, or they're a little more short of breath than usual. Those nurses go out and they can communicate with our medical director and or the patient's physician. And it's that interaction with the physicians and updating the physicians. Debbie takes some updated notes and what have you to the primary care physician so they know what our clinicians are saying, and it keeps them out of the hospital. However,
So what kind of options are available for families for respite? You mentioned. Go ahead.
respite is a part of the Medicare hospice benefit, and it is 5 days
5 days.
for family caregiver support's breaking down, they need to go out of town to a wedding or whatever, and that patient is transferred to one of our skilled facilities, which means we have a contract to provide hospice care in their facility, and everything is finely detailed in that contract as far as who provides what. Again, our nurses, our social workers, our CNAs, they all continue to visit that patient because it is our patient and it is our responsibility, and suddenly they're in a different place and they need to see familiar faces that they trust.
That's right.
That is also covered.
And once we
100%.
do that, once somebody goes into respite, if, for instance, they were getting a nurse 2 times a week and the social worker's just visiting a couple of times a month, we increase our visits to daily contact from somebody on the team.
Gotcha.
Because they're in a different environment and they're not seeing their family 24/7. So they need something that's familiar. So our staff continues and increases the visit during those 5 days. We meet them at the facility to get them settled and tucked in. That's usually the nurse, sometimes the social worker. And then when they go home, 5 days later, we meet them at the house to get them tucked back in and settled at home. So it's a complete package when they go. They get a lot more.
That's great.
And they're not lost in the system.
Yes.
Absolutely. And then there's interaction with the facility the whole time that they're in there. Whoever's going in is talking to the director of nursing or the nurse that's on the hall, whoever that they need to just communicate what's going on when we haven't been here. Here's what I saw today. So there's a collaborative effort for that.
That information
care.
you're usually getting from the family.
Yeah.
You know, which, okay.
Absolutely.
Good.